people will, yeah, we're hoping that more will join as the session goes along. But thanks for being here. I know Saturdays are hard, but we wanted to accommodate the international time zones of our participants. I'm Arun Gosain. I'm the president of the American Association of Plastic Surgeons, and we're really pleased to have this webinar. And the topic is the needs in global health from the perspective of low and middle income countries. And the reason I wanted this to be discussed is so much of our global health work is America centric. We'll start with America and say, okay, we have these surgeons who want to do this. Where should we go? And if you look on websites, it's okay. Here's the next trip. Let's sign up. But it's really not centered around the needs of the places that we are trying to serve in terms of sustainability and long-term health of that population. So what our focus today is going to be to try to see what are their needs, and then we can help to come to solutions over time as how can we best serve those needs as coming from a more privileged society. I'm going to just introduce the various members of the team, and then I'll let Dr. Bustamante take over as the moderator. The Dr. Atinas Bustamante is our moderator. She's from the Operation Smile Women in Medicine program, and she is at the Hospital Nacional Carlos Alberto Escobedo in Arequipa, Peru. Her panelists include Dr. Opuku Ampoma, who is a plastic surgeon and past CEO of the Corlebu Teaching Hospital in Accra, Ghana. He's the director of the National Reconstructive and Burn Center in Accra, and this is the largest hospital in West Africa. Dr. Gaurav Deshpande is a cleft surgeon from India. He was the main cleft surgeon at Guwahati GC4, which was probably the busiest cleft center in the world during that span in which it worked. And I think in the first 5 years, they did 5,000 clefts, if I'm correct, Gaurav, somewhere in that range. But I had a chance to work with him. He's an excellent cleft surgeon, an excellent teacher, and it's so great to have him here. He then spent time in Mumbai at a cleft center there, which is his hometown, and he's currently working as Vice President of Medical Oversight at Operation Smile. Dr. Wisława Palikowski, and if I'm saying it wrong, she'll correct me, of course, is a plastic surgeon from Peru who served as the head of the delegation of the Ministry of Health of Peru to the World Health Organization. She's at the largest children's hospital in Lima, Peru, and she's currently the Director of International Cooperation of the Ministry of Development and Social Inclusion. So our panel and panelists really include some of the leaders in world health, and it's such an honor to have them here. So Dr. Bustamante, I'll let you take over.
Good morning, everyone. Thank you, Dr. Arun, for the introduction. It is my pleasure to serve as your moderator today in this very insightful and exciting panel. Today, we will aim to shed light on the pressing issues that plastic surgeons in low and middle income countries face, while we explore collaborative pathways for meaningful and sustainable solutions. So we believe this webinar is an opportunity for us to be able to engage in a global conversation about equity, sustainability, and collaboration in plastic surgery. So we encourage all participants to actively engage, ask questions. As you have seen, our panelists today are highly trained, and they have a lot of experience in their fields and in their countries. So please participate in this dialogue. We will start with the first question that we have for them today. What are the key areas of need for plastic surgeons in your country? So Dr. Ampoma, if you could, we will start with you. Thank you.
Hi, good day, everyone, and it's a privilege to be part of this discussion where we are talking about the real needs for plastic surgeons in global health and looking at the perspective from low and middle income. To just give you a little bit of background about the history of plastic surgery in Ghana, and then I'm going to look at the various questions as to what the needs are and what local surgeons can do to help to provide more support for plastic surgery services, and then to look at what's the best way for in terms of international collaboration and what impact it can bring into the local situation. Next slide, please. Next slide, please. Good. So Ghana is a country which is in West Africa. It's located on the Greenwich Meridian. In fact, it's a country that is on the longitude 0, and then it's also closer to the equator. So we describe ourselves as being at the center of the earth. Next slide. Next slide, please. Can I have the next slide, please? Good. So that's our center, which is located in the Kulebu Teaching Hospital, which was started by a visiting Scottish surgeon, famous for some flaps in head and neck reconstruction, called Jack Mustadi. So he visited Ghana in 1992 and realized that there was no plastic surgery service in Ghana, and got in touch with our president and then decided to start the service. So through the fundraising efforts of Jack Mustadi's charity, which is now called Research Africa, the first plastic surgery center was established and commissioned in April 1997. Next slide. So initially, the service was handled by visiting plastic surgeons who came in terms of rotations. And during this period, local surgeons were trained, and they have since taken over the service delivery. And subsequently, so now the center has expanded with a new building. So we now have a total of 92 beds, including 6 ICU beds, 6 ATU beds, 3 theaters, and about 8 different types of wards. And so we have a burn wing, general plastic surgery wing, and then an ulcer wing, and then we have what we call an executive ward, which is for people who are the middle, more like middle class, upper class patients. But then we also make sure that nurses and physiotherapists and other allied health professionals were trained to provide that kind of support to the surgeon. And so in terms of postgraduate training, we have a locally based training program, which is accredited by the West African College of Surgeons, and more recently it's been accredited by the Ghana College of Physicians and Surgeons. And so our trainees go through the training program, which is after basic medical training. It's a 6-year-long program where you do 3 years in basic surgical training or general surgical training, and then you do another 3 years, which is in plastic surgery specifically. And after the training, what we do is try and partner with other hospitals, other centers of excellence around the world to provide them some additional top-up training. Next slide, please. Next slide. So our top 10 cases are keloids and scar-related problems. Acute burns are very high. As you are aware, about 80% of burns occur in low and middle income countries, and Ghana is not an exception. So we see a very high number of burns, very massive burns, and the top causes in children are, hot water, hot liquid burns, and then a strong second is gas explosions, because we are switching to the use of domestic gas. So now we've seen a lot of people, with burns from gas explosions. We also see soft tissue trauma, cleft lip and palate, and other congenital anomalies, and post-burn contracts and tumors. We do a little bit of cosmetic work, but I'll say that it takes about just maybe 5 to 10% of what we do. Next slide, please. Now, the key areas of need. One of the key areas is manpower. Although we've done a lot of work has been done to improve the number of plastic surgeons. At the moment we have a population of about almost about 35 million people, but we still have plastic surgery numbers under 30 as we speak. And so you can see that there's quite a huge need. And we now have about 16 regions in the country. And out of these 16 regions, only 4 have got plastic surgery present. So you can see that the plastic surgery manpower is really limited, in the country. So efforts continue to be made to improve in the numbers in terms of facilitating training and encouraging training. And then also, we are also not just looking at surgeons, but also looking at critical care nurses and nurses who are trained specifically with burns, physiotherapists, nutritionists, psychologists, occupational therapists, and also microbiologists. And so because of the limited number of consultants, so means that during the training of undergraduates, they would have kind of limited subspecialty exposure. And that is why we try to collaborate with centers outside Ghana, so that after their initial basic training and fellowship, they can get some top-up training. Of course, infrastructure is a huge concern. Although we have a lot of the basics covered, we still need to, looking at the number of our burn cases, we still need to have a proper purpose-built burn unit, because what we have now will more of what let's qualify as not as a proper like burn center with all the ancillary facilities that is needed to be able to improve upon the survival chances of burn patients. And so logistics are also another huge concern, where surgeons have to in terms of equipment and some of the other things that advanced things like barbaric oxygen, skin substitutes, and all the things that other areas take for granted. So these are all a question of concern. Although in terms of logistics, we do have an operative microscope, but it's just one. So I shudder to think of when if this one has any problem, then means that our microsurgery capabilities will be strictly, will be severely restricted. And so these are some of the challenges of like basic equipment to make the life to make more easier and more successful issue. We at the moment they have the challenge is that so nominally they'll say that burns are covered, etc. But then how can you expect a burn unit to use a funding of about between $100 and $120 to take care of somebody who comes in with a 50% burn? So it's just like a drop in the bucket, and it's really not. So we have to fall on the individual patients or philanthropists to support care, and that is not sustainable. So the healthcare financing model has to be looked at so that those who need care can really access care. Next slide, please. So the issues of also psychosocial rehabilitation. We've managed to employ some psychologists and occupational therapists recently, but their numbers are few, and this is something that needs to work. And of course, we also like to look at skin banking, tissue culture, prosthetics and orthotics services. All these are virtually the prosthetic orthotic services virtually virtually non-existent. So all these are things that we would like to see happen. So these are areas for potential collaboration and support. Next slide. We also look at access to training courses. The average incomes in Ghana are quite low. For a plastic surgeon, for instance, consultant plastic surgeon, the government salary, the salary is less than $2,000 a month. And so, and for trainees, it's even less. It's just about less than just a little under $1,000 a month. And so, if they have to pay for foreign courses and workshops and things like that, it becomes a bit of a challenge. And so, access to training courses is one of the areas of need. And now that there's internet with all these webinars, etc., if there's a way of giving some support to provide access to some of these courses, it helps. We're also looking at the development of protocols, standard guidelines for various conditions. Although some of the basic ones have been developed, but this is an area of development which can also benefit from some collaboration. And then we also institution formal training in bands and classes for nurses. And the other issues, which I talked about already, is compensation, because the salary levels are low. So once people become highly trained, it becomes a bit of also a challenge to keep them, locally, and to keep them within the local space, because now after COVID, a lot of them have any of our surgeons yet, but then it's a matter of time. So we are looking at ways of making sure that they can get some reasonable compensation so that it keeps them on the ground, so that they can provide the service locally. Next slide, please. Ghana is not, next slide. Ghana is not alone when it comes to, you can see in the West African and African region, generally, the numbers of plastic surgeons are very, very low for most of the countries. So this is an area of this. So we need to develop manpower. And by default, Ghana has become, next slide, please. Ghana has become a training hub for plastic surgeons. So we've had surgeons come from Nigeria, from Sierra Leone. In fact, the first 2 plastic surgeons for Sierra Leone were trained as the first female plastic surgeon from Zambia. So she came and trained our unit. And on the left is one of our trainees who passed out recently. So between when I qualified in 2005 as a plastic surgeon, we were only 5 plastic surgeons in the country. Now, at least we'll be able to increase the numbers to around 30, but this is still not enough, and we need to increase the numbers. Next slide, please. So in terms of what local surgeons can do to ensure that there's funding or access, or there's improved access, or there's more funding is attracted to plastic surgery, what we continue to do is to control advocacy, like what we are doing on this platform. And then also making sure that we are doing the research and coming out with research, the proper documentation and the data, so that the data can help us to make on the mass media platforms through seminars, webinars, etc. And also strategic partnerships, which I'll be going to shortly, have also helped to try to improve the situation and also bring to bear some good support for the plastic surgery services. Also, community engagement, media strategy, and also champions program, using both local and international champions to help to bring to light some of the key challenges in the area of plastic and reconstructive surgery. Next slide. And so all these centers, or these are some of the people that we've collaborated with to provide support in one way or the other to improve other manpower, infrastructure, logistics within the plastic surgery service in Ghana. Next slide. So next slide, please. So Research Africa, which was started by Jack Mostadi, has supported infrastructure, logistic training over the last 27 years, and they still continue to support some of the training programs. On the middle is Martin Webster, who used to be the president of the European Association of Plastic Surgeons, and the current chairman is Oron Shelley on the right, and who is currently the president of the British Burn Association. Next slide, please. Interburns, which is the International Network for Training, Education, and Research in Burns, has also been one of our consistent partners, helping us to develop training programs, not just for Africa, but for low and middle income countries, especially in Southeast Asia, also some of the other African countries, Malawi, Sierra Leone, Ghana, and so we also started sign an MOU to start a Burn Fellowship program in Accra. Next slide, please. We've also had collaboration with Research International, used to be called Interplast. And so through them, we held some ear reconstruction workshops. So we've actually started an ear reconstruction service in Accra, which is being led by one of my colleagues, Dr. Albert Payne. So next slide, please. Operation Smile has been one of our biggest partners, and I'm sure Operation Smile is no stranger to all of you. And previous, Operation Smile has provided a lot of opportunities for training, for collaboration, and also, and now they are currently investing in health system strengthening and capacity building. In fact, and through Operation Smile's efforts, we were able to launch our first national surgical obstetric and anesthesia plan, which is a big milestone. But this gives us some building blocks to follow to improve surgical and obstetric and anesthesia presence within Ghana. Next slide, please. So this is Operation Smart. That's Ruben Ayala on the top left, and the Operation Smart when they came down. This is the launch of the National Surgical Obstetric and Anesthesia Plan. Next slide, please. So I've talked about Canisman Plastic Surgery Unit in Glasgow, where I trained, and a number of my trainees have also been there for various training programs. Next slide, please. Next slide, please. Hello, next slide, please. Next slide.
Would you like to bypass the Ghana hospital?
Yes, to go to Ganga Hospital. Next slide, please. Yes, so the Ganga Hospital is also one of the places where we've sent our nurses and our trainees for, for training various aspects of reconstructive surgery, hand surgery, microsurgery, etc. And it's also a place which has a high, caseload and also high quality in terms of skill, and the logistics that are available. Next slide, please. Next slide. Hello, next slide, please. Next slide. Okay, so some of the successes that have been chalked in the can include establishment of in-country flag, because previously we had to take our surgeons abroad for training. We've also, through the help of the British High Commissioner, been able to establish a microsurgery unit, training unit within our departments where we can teach our residents and the basics of microsurgery. We've also started a training program, postgraduate training program for nurses in burn care. So we've now, in fact, the third cohort is about to graduate the end of next month. So in total, we've trained about 120 nurses in this program. So this is some of the outcomes of successful partnerships. Next slide. Next slide, please. Next slide, please. Next slide. We also, as part of us, we also undertake, because of the limited spread of plastic surgery service, we also undertake outreaches to the rural areas or underserved districts to provide the care closer to the community. And so this is an area of collaboration as well. So outside our outreach work for Operation Smile, we also do these other outreaches where in a week we're able to operate on between 100 and 200 patients with various surgical conditions. And so since 2012, we've done this, and about 3,000 patients have benefited so far. Next slide. Next slide, please. That's our present inaugurating our new ICU building. Next slide. Next slide, please. Next, these are just pictures to show you some of the activities that have gone on. Next slide. Next slide. So that's the training of training interventions. Next slide. So that's the British High Commissioner, former British High Commissioner Ian Walker, who helped us to raise funds for to establish the microsurgery lab. You know, he did a 1,000-kilometer cycling trip around the country. You know, raising awareness about burns, etc. And yeah, he asked me to do one of the most difficult things I've ever done in my life, where he asked me to cycle the last 100 kilometers with him and with his well-built team. And I nearly got killed in the process, but I managed to get to the end. Next slide. So at the moment, we are also undertaking a collaboration with the Caribbean units, Microsoft, and Glasgow School of Art and Strathclyde University, where we are looking at 3D teleportation to be used for patient planning, surgical planning, etc. So this is something that is ongoing at the moment. Next slide. Next slide, please. Okay, so now I want to look at our current situation, how best surgeons from the US or other European countries can help to contribute to some of these things. So one of the first things to look at is collaborating and mentoring arrangements where institutions can partner specific institutions and so that to facilitate skills and knowledge exchange. Also, visiting fellowships, visiting professorships can be established. But this has to be done in a deliberate manner because there's no point scattering yourself all over the place. So now that it is known that, let's say, a place like Accra has got a certain capacity for training and development, then it will be best to invest in a hub so that the surrounding countries or surrounding districts can then be brought into this hub for training, so that when visitors come from outside, they will have slightly more advanced place to work with because they are used to, and then so that this can then make best use of the resources because if you go to a place where there's very little, then you not really be able to achieve much. So this hub and spoke model is what we think would work best in our kind of environment, so that you identify a hub where you can support around it. And then research capacity enhancement is also one of the key things we are looking for. There's a lot of unwritten research because we do see a lot of pathology, but if you look at research outputs out there, you can see that they don't have those pathologies. So and this is one of the areas that can benefit from collaboration. Then we can also look at specific projects around particular disease conditions or particular subspecialty areas, and all these can also help to improve upon what we do. And so this should be should be a collaborative effort, and also infrastructure and logistics support as when needed or as would be relevant to a particular institution can be looked at. Next slide, please. Now, I'll just have a couple of minutes, just to share a few thoughts on what some of the partnerships we had, what are sustained these partnerships. So it's based on mutual respect. And I think one of my colleague panelists made a point during our discussion that sometimes people pitch up from abroad and think they don't have the solution to the problem, but it's best to to listen to the local people and understand the local context before solutions are prescribed. And so I think the best way to do it is to do so through a mutual process. Next slide, please. Next slide, please. One of the things that has also worked for us is to emphasis on quality and standards. Sometimes there's a temptation to think that because this is maybe something is being done in a low and middle income country, means it can be of a lower quality. But actually, I have a different opinion that those who are in the low and middle income actually have to have, even in terms of their skill levels, they have to have even greater amount of skill because they are working with fewer resources. And so they really have to appreciate and understand what they are doing so that they do not end up creating unnecessary complications, because patients have to pay for everything that you do for them because of the way the healthcare system is funded. And so if you do an unnecessary operation or a patient that does not achieve the best outcome, then you have not really served the patient well. So standards must be insisted on. And also efficient organization of programs is very necessary. And also with some of these things, you have to take a long-term view. So sometimes people start partnership and expect an overnight or an imperative or a success imperative from fund providers. But I think you need to know that it takes a bit of time for some of these things to materialize. Next slide. It's also important to insist on honesty, integrity, and transparency, especially with financial issues, and things must be communicated clearly. There should be inclusiveness and fairness in approach. And also, it shouldn't just be about surgeons, but we should also make sure that the other members of the team are also included. And also, we engage the local leadership. It's very, very important. Communication it goes without saying that for any successful collaboration and partnership, good communication must be established, and what works best for the group must be decided. And then also some of these mentors, some of the people who are outside can take on some of our residents and mentor them and help them to grow in various specialties. Next slide, please. Next slide, please. So in terms of some of the challenges to successful partnerships, cultural differences are there. So, we have to, understand some of the cultural nuances in behavior, and religious beliefs, ethnicity, work ethics, time management, all those things have to be navigated. Traditional and political authorities must also be notified appropriately so that when you are entering any community to do any significant work, it's best to make sure that you enter through the front door. Sometimes you have the situation where people have a friend and then they engage them to do and take an intervention, and then on the blind side of the hospital authorities. And so what happens is that once that individual leaves the institution, that's the end of that collaboration. So for long-term sustainability, it's important to make sure that you involve all the key people in the process. And next slide, please. And sometimes when we overfocus on a particular disease or a particular program to the detriment of the other related issues, then it creates a certain unintended consequence of a dependency syndrome, or like I know some NGOs have this, have this arrangement where if you operate on a particular condition, you send them a picture and then they send you money. Then that's the unintended consequence, that people will then begin to focus just on those ones because of the financial reward and forget about some of the other conditions in their brain, even though they may be even more pressing. And so that must be avoided in some of these arrangements. And then also the issue of corruption, because there have been instances where donors are brought in support and then it doesn't end up doing the job which was intended. So it's important that we should trust people, but we must also make sure that there are verification process in place to make sure that there's a proper accountability for all the things that are being done. Next slide, please. So what are some of the future areas of collaboration? We are looking at tissue viability, reconstructive microsurgery, deepening our burn care services, and making sure that we have modern facilities for to provide support for our burn patients. Also, the efforts at prevention must be deepened. And so there's a lot that can be done with local and international partnerships, and also with the appropriate political will and collaboration, and using appropriate technology for the environment. And there's a lot that can be achieved. Next slide, please. So I end with a quote by Ellen Keller, which says that alone we can do so little, together we can do so much. Next slide. And there's an African proverb which says that if you want to go fast, go alone. If you want to go far, go together. So I believe that collaboration across the different specialties or subspecialties is the way to go, to make sure that we can bring some improvement or meaningful, or we can make meaningful impact to the situation of plastic surgery and burn care within the African, or sub-region, or in low and middle income countries. On that note, I thank you for your attention.
Thank you very much, Dr. Rampoma. That was a very comprehensive review of the current situation of plastic surgery in Ghana. Now I'd like to give the word to Dr. Gaurav. What are the key areas of need for plastic surgeons in your country?
Thanks so much, Dinas, and thank you so much, Dr. Gosain, for this opportunity, and thank you so much for whoever is attending. Thank you for your time. I've had the pleasure to first meet and work with Dr. Gosain at Guwahati Comprehensive Cleft Care Center. He mentioned about it briefly during the introduction. We actually did 16,000 surgeries, Dr. Gosain, in that first 4 years. So it was actually the busiest cleft center in the world. The need was just there. Like, that was one need. And I was very lucky in my early career to actually work in a center like this, where, you actually have a lot of clinical load, but also have help from, people like Dr. Gosain, Dr. Mackay, I think he's on the panel list as well, and a few others who used to come there and, just help us. So in the current role that I have right now, serving as a, AVP of the Medical Oversight and Safety Department at Operation Smile, I also get a chance to, work with the foundations from 39 different countries. And before that, I was a volunteer where, I traveled for more than 35 programs. So I have seen a majority of the low middle income countries need. Today's what I'm going to do is concentrate on India, because that's my birth country. That's the country where I spent most of my years before migrating to the US. We all know that India is the most populous country in the world. We recently overtook China, and now we're at 1.4, 1.5 billion people. So the need is huge. And if I just segregate it into 3 or 4 major buckets, I think the first bucket would be the clinical needs. There are 2,000 plastic surgeons as of the recent data in India. Although the numbers might sound big, they are probably 5.3% of the total plastic surgeons in the world. But we have 1.4 billion people. And we also have to remember that the 2,000 plastic surgeons, which are there, majority of them serve in the urban regions. And if you know India a little bit, the majority of the population is based in rural areas. So you can imagine that the access to safe and high quality plastic surgery is very, very limited. The district hospitals, they don't even have plastic surgery as a specialty. There might be a few exceptions, but majority of the district hospitals, they do not have plastic surgery as a specialty. So if you have a need, you have to travel far and, to the urban areas like Mumbai, Pune, Delhi, where there are too many plastic surgeons. And then, it's just confusing that how do I get the proper care and who is the right person for me? So from the clinical load, I think there are the top 3 kind of buckets, mostly are burns. Dr. Rampoma, I have the pleasure of working with him in Ghana as well. We see how much that is. Also in certain other countries, joining India, Nepal is one where Dr. Rai is doing a fantastic job. Again, tremendous load of burn patients, reconstructive care after trauma, after cancer surgeries, and cleft lip and palate. Obviously, these 3 or 4 areas are the most important needs. in India and adjoining regions from plastic surgery clinical point of view. Then if I talk a little bit about the second bucket is the education and research. There are 298 seats of plastic surgery, residency seats, I mean, in India. Again, not enough for the vast majority of the population. Again, not enough to cater to the rural population. Although, again, it's the numbers are big, but again, when you see comparatively with the number of people that they're serving, it's just very minuscule. Research, I mean, most of the times, being myself trained and educated in India, I know how there is such a large scope that we can actually contribute to. But since there are not enough training and education on how to do research at a young age, we just are not very inclined towards doing research. And I feel sad that many times that we have such a lot of caseload, and if that training has been given initially, and we just groomed on how to do a good high quality research, I mean, there are so many answers that could be answered, so many questions that could be answered through that endeavor. And the last, I think Dr. Amboma eloquently described the resources. Affordability is a major challenge. There is a big need for plastic surgery, but obviously there is no national universal health system in India. Most of the times, the medical fees are covered by private insurances. Majority of the population do not afford those insurances. The government has some schemes, but again, they are far-fetched. They're not very commonly available. So the affordability from the patient perspective is just impossible. Like, they just do not know what resources are available and how to access them. From a provider perspective, the resources, there are very few burn centers. Like, I'm just giving you an example of burn because that's a pressing problem in India. And I mean, if burn centers or burn units are so little, you can imagine how few reconstructive care is there in India. So the resources challenges are obviously, the government's trying their best with new schemes that are coming in. Things are getting better, but again, the need is so high in terms of the resources that obviously, it's just not sufficient, and many people, they do not have access to safe and high quality surgical care in most of the parts. So that's the perspective from India. Atinas, over to you.
Thank you, Dr. Gaurav. It's really good to be able to see your perspective, and I'm sure now you have a different perspective being in the US and how things are different. Dr. Vyaslava, for you, the same question. What are the key areas of need for plastic surgeons in Peru?
First of all, I want to thank for the invitation. Thank you, Arun. Thank you for the invitation, the American Association of Plastic Surgery. And thank you for the introduction, Athenas. It's a real privilege to share with all of you this panel. And I work in Peru. Peru is in South America. Our population is around 35 million people. First of all, I'm very sorry about my English. Please try to understand me. And 30% of this population are in the capital, Lima. And we have many problems with the plastic. First of all, we are only 400 plastic surgeons in Peru. And many of these, more than 70%, are in private practice. And the public hospitals needs for plastic surgeons. This is number one. And the second is the plastic surgeon who works in the hospital are in the big cities, in 4 or 5 cities in Peru. And the small cities or cities in the borders or in the jungles or the hills, we don't have plastic surgeons in that areas. So the concentrated are in urban regions and in big city, and only very few plastic surgeons. This is one of the problems, no? Where are our plastic surgeons? And we have 30 million people. We need a surgeon who solve the problem in soft trauma tissues with burn patients, post-scar burns, hand deformities, congenital hand malformation. We need a problems with cleft and palate, and different areas that the plastic surgery have the expertises. And this is one of the problems. The second is the education, as Gurav talked about. No, we have a very few programs, university programs provide this type of training, only 5 or 6, and we have only 40 or 30 new plastic surgery every year. But again, 70% goes to the private practice. And the other who works in the hospitals needs to improve the knowledge with different fellowship to know the microsurgery or craniofacial problems, to resolve craniofacial problems, microsurgery or special reconstruction for cancer problems. And we have a good but not perfect health system of health. 90% of 99% of the population are covered with this health system, but we don't have doctors to resolve the problem. So if we have one person with suffer a big burn in the jungle, we have the resources in the jungle, but we don't have the doctors, we don't have a plastic surgeons to resolve that. So this person have to come to Lima to try to resolve. So our hospitals in Lima, the capital of the big cities, 2 or 3, one is the Atenas Live in Arequipa in the south, or in the north, Trujillo, that Arun, you visit several years ago, are absolutely collapsed with the patient who come in for the different small towns looking for the plastic surgeons because we don't have plastic outside of the big cities. This is the key, the real needs of improvement.
Thank you, Dr. Visava. And to add to what you said, because we both have similar realities in Peru, in my hospital, there's only 3 plastic surgeons right now, and we have to take care of all the southern area of Peru because we are a reference hospital. But our wait list for elective plastic surgery is around 6 months for patients who are not in critical condition or do not have any acute conditions. And there's only 3 of us, and we obviously have to take care of acute burns, acute reconstruction, trauma, etc. So, we have patients coming to the consult. When am I getting my surgery? And unfortunately, we have to say, patients whose surgical risk, anesthesia, all those exams are about to expire because they got them almost a year ago. And we have to say, sorry, there's not enough of us. And we also don't have enough, we can't do enough surgeries because there's only 3, like Dr. Visava is saying. So like she mentioned, like he need is to have more professionals that are employed in the big hospitals. So it's a reality that we see every day. To move on to our second question, how can surgeons from low and middle income countries help to direct government funding to address these needs so that they can become self-sustaining? Dr. Gaurav.
Sure. Thank you so much, Adinas. I think the key is policy and advocacy. Like what policy and advocacy basically does is just show the reality of what's happening in the country in terms of health and health needs to the political leaders. I mean, just not, many times, the ministers that I've experienced this in myself, that they feel that, they do some new schemes and new programs, and, they feel that's well, they've done so much, and that's the end of it, right? And everybody is happy, and the world is a better place. But I mean, it's just our responsibility to just keep telling them, no, that's not enough. There is so much more to be done. So I think a thorough policy and advocacy team, and we are Operation Smile are so lucky to have Ruben Ayala, who has been tirelessly doing that, and we've already heard Dr. Ampuma mention the fruits, like the NSOP in Ghana was achieved by that. So the ministers in Ghana now at least are on board. There are so many other countries that need more work. The second thing I think is, and this I learned a little bit after getting a business degree, is, just showing how much money, these efforts can bring into the government is so helpful. What I mean is, now imagine a patient with a severe burn deformity, or imagine a patient with untreated cleft lip and palate, right? They grow up and they are just not able to be independent. They stay with their parents. They cannot have a job because they're not confident. They're not able to function properly. The parents obviously now have to take care of their children, so obviously their share of the income tax, the income tax that they pay is reduced. This new child now grows up, does not work, he does not pay any income tax. So there was a fantastic paper that came out of Philippines. It was a modeling paper, so there were a lot of ifs in that. But what it showed is that by not giving the proper reconstructive care to the backlog of the patients that they have, just for clefts I'm talking about, in Philippines, the government was missing, I think it was $120 million every year, the US dollars that Philippines government was missing out, in taxes that they could have got if there was reconstructive care given to these children, these adults now. So, I mean, it's just, if there's a way to tell government is like, we just need a loan right now. And from a cleft perspective, from cleft lip palate perspective, it's $250, $300. Give us $300 loan for this person. When this person grows up, he's going to pay much, much more back to you. So, again, it's a very theoretical concept, but, it happens. We all know it happens, but just showing them reality, the impact, not just from finance, but also the quality of life. It's your people that needs this care, and you can contribute to it. So I think that, and then just having a realistic ask, this is what I need, being very specific, from different perspectives, and just give that need to the government. And then then slowly, how, if you can even plan it out, in Mumbai, when I started a cleft center there, I actually went to the commissioner's office and gave him the exact needs that we had in a very, very specific manner. And he was like, well, okay, you've made my job easier. So like, if we can do their job for them, I think that helps a lot as well. So that's my perspective.
Dr. Visava, having worked in the Ministry of Health and now in the Ministry of Inclusion and Social Change, how do you think surgeons can help direct government funding to address these needs?
Well, I have an experience 18 years ago when I was part of the Plastic Society, Peruvian Plastic Society. In that time, Peru offered only one or two places for training in plastic surgery in all of the country, because the government, when they thought about plastic, only believe in aesthetic. And the policy and advocacy is very, very important, because we have to talk first with all the universities about the needs to the part of the reconstruction, the burns, the microsurgery, all of the part that the patient needs in the different hospitals, to open the places, the opportunity to train doctors in plastic. And then after that, we have to talk with the government, with the Minister of Health, to open the hospitals for train the students. Because here in Peru, the law is nobody can train without salary. And the government have a number of trainings for years. For example, 10,000. And in this 10,000 for training, have to share for different specialties, plastic, neurosurgery, pediatrician, or whatever. And we don't have more than this number of trainings. And in that time, the government of Peru offered only one a year, and this other year, 2 space for training plastic. After that, they take us for 3 years. After 3 years to talk, they open more spaces, more places, no? To 4, 6, and 7, and little by little, we increase the number of the places who offer the train for plastic. That is why now we have more residents in plastic, but we need more because, as you know, the small cities, cities inside the country, we don't have plastic in big hospitals. And I believe the way is policy and advocacy. Thank you.
Thank you, Dr. Vyaslava. Just to add to what you just said, here in Arequipa, we only have one plastic surgery residency spot every 2 years in the Ministry of Health hospital, and my hospital does not have any plastic surgery residents. So I completely understand what you mean. To our next question, how can surgeons from the US best contribute to these needs, Dr. Gorav?
Thanks. I think, just going back to the need and just trying to tie up this question to those, there can be, there is definitely the help that is needed in taking the clinical load off, right? Like, so medical programs. I know, that's a very a debatable topic, but we've all seen for many, many years that's been done with the very high impact of just taking care of the clinical load, just helping people out. So we definitely should not discount the importance of medical missions, medical programs that happens around the world and in different just plastic surgery, but different subspecialties in that. So that's one. I think that's been done since many years. That should continue in a more regulated manner, if that is the right word. Would definitely be a help. But the more important point is that the surgeons from the US can help the low middle income countries is in threefold. One is education and training. I think that's the most critical element. Dr. Ampoma also shared a few of his slides and on how he is concentrating on that, like with the help of so many collaborations from outside of Ghana who are coming in and just trying to teach the local surgeons into state of the art. I myself have been the beneficiary of that. When I was in Guwahati, I had the privilege of being alongside Dr. Gossain, Dr. Mackay, and David Fisher, like the stalwarts in plastic surgery, and just learn from them. You obviously have your own ways of doing things, but just that tips and tricks from Dr. Gossain, who would spend the entire day in the operating room, just helping the local surgeons, get better in their skills. And that has a huge impact, on everybody's skills. Just the quality of surgery just improves so much. From research point of view, again, if you are able to, like, if they can just, and this can be done online, it's pretty easy. Just give the tools of how to do high quality research. I think that would be very helpful. From the beginning, maybe we can collaborate with the medical schools, with the universities in the country, and then we have these collaborations with let's say Lurie Children's, where Dr. Gossain, I don't know if he's still there, but used to work, or Penn State, where I'm a clinical assistant professor with Dr. Mackay. So these collaborations help a lot in just giving those tools to this young budding plastic surgeons in these countries. The third thing is, have an exchange. Like, we always say that, okay, we will come and help you take care of the load, but then how can we have a bilateral, bidirectional exchange? We can send medical students, doctors from US to, let's say, India, but how can we get the Indian surgeons to Lurie or Penn State, which, again, I was a beneficiary of. I tremendously learned how things are done in the high income countries. And just like, even though we don't have the resources, but just like there are certain practices that can be definitely imbibed on. And again, speaking from personal experience, I was very lucky to get those. So the bidirectional kind of exchange, rather than just saying that, okay, let me come and save the world for you, how can we also involve them? Like, come over and we will show you how we do things, and learn from you. And the last is resource. Like, many times it has happened in the past that the politicians in that country do not listen to the local leaders. But when somebody comes from the US, immediately checks are signed. Sad reality, but that's true. So again, if surgeons from US can help in that policy and advocacy endeavor for the local surgeons, I think that would be a great need. There are certain small things that also can be done. In US, we know that we can't reuse certain medical devices, but in countries in low middle income countries, there is a need. So rather than throwing them away, if we can save those medical devices like RED, the rigid external device, which is so expensive for maxillary distraction, like we could autoclave them and use it in another patient in India. I've done that. So small things like this also are very helpful. There's no way that people and patients in India could afford a $5,000 medical device. So there are various ways of doing that, but obviously in different buckets, and a lot can be done together.
Thank you, Dr. Gaurav. Those are great ways that we can work together and collaborate with US surgeons to help our patients in need and our plastic surgery workforce. Dr. Visava, what are your thoughts? How can surgeons from the US best contribute to the needs of plastic surgeons in your country?
Well, I think we have different ways to collaboration, no? Mentoring, an exchange of knowledge and skills, I think is very important. Visitor fellows, visitor professor, I think it's important because this exchange of experience improve the knowledge and permit the doctors in country knows the new technologies, and the young people knows different experience. And I think this is one of the best part of the collaborating with the doctors outside of Peru, no? But all of these have to be like part of a partnership. No, not like one or two alone visiting, no? I think there have been a part of a program, because it's on if the visiting is once in the time, I think it's not a good idea, because at the end of the visit, the people don't believe don't believe with the partners. I think if it's consistent year by year for a long time, and train the same people during a period, the people assume the compromise and wait for the visit, develop a relation with the doctors. The nurses wait for the for the visit, the patient wait for the mission, for the program. And I think this is the best part of this exchange of the programs. I work in the Children's Hospital for more than 25 years, and I have this kind of exchange, with different programs, with craniofacial programs, with hand programs, with cleft and lip. And I can believe if this is sustainable in the time, the nurses, the anesthesiologists, all of team improve your knowledge, improve the protocols, knows how works like a teamwork, and the treatment that provide to the patient improves as well. No, I believe this is the way that the U.S. surgeons can help the doctors and the plastic surgeons in country like mine.
Dr. Ampoma, I think you spoke a lot about partnerships with your Corlebu Hospital. Maybe you can highlight a partnership that you have found very beneficial to your surgeons from outside universities or countries.
Thank you very much. So the number of partnerships. In fact, there's one currently ongoing with Operation Smile, where we took a comprehensive view of how can we improve upon the outcomes in terms of cleft patients. So we looked at an area which was the difficult palate, or speech surgery, and so we actually planned a program around that where we brought in, people who are this area, from abroad, and had specific programs where we, pull these kind of patients, and then we had these training workshops over about a week. And so we've done that consistently over the past 3 years, and this has improved significantly on the outcomes in terms of speech for collaborative arenas, and how it's helping. And so we also have ships extra, to bring to bear this expertise on the local to see explore. There's also research partnerships, because as been said earlier, there's a lot of data published. I mean, sometimes it's quite interesting that you go for international meetings, somebody presents a series of maybe about 30 cases of pathology that you see often in your clinic, and it's somebody says about 13, and it's a whole series, and then it's making noise about more than that number, So, but it's because Gaurav equipped with the necessary tools to conduct high quality. Those from the US are bringing their research expertise. They can help us to develop highly robust, or good high quality studies, and then it can be a win-win for everybody. And I also believe that it's not just knowledge coming from that side, because now, if you are a surgeon and you want to train in burns, for instance, if you stay in the US, you may probably not see enough cases, but then here, I mean, they are all over the place. And so those essays can be both ways, where we bring in residents from the US or other places, advanced countries, to come in and see what the pathology is and how the local situation is. And then we also benefit from their knowledge and skills, and I think to be a win-win for everybody.
Thank you, doctors. I think we can all agree that the best part of all of this is collaboration and sharing and exchange of information. I think we have touched a little bit on our last question as well, about how can we optimize the education of local surgeons through collaborations with surgeons from the US and Europe. I don't know if you have anything extra that you'd like to add, any additional comments. We'll start with you, Dr. Gaurav.
I think, Athenas, we've covered this. Again, re-emphasizing the bidirectional kind of learning. I think that is the key. What Operation Smile is doing now is, there's a lot of effort on education and training. So we are actually trying to, pair an educator with the mentee. So we are finding out mentees in the, our program countries and specific hospitals, and then we are pairing them with one educator. So, in the past, what happened is, there was education training always on Operation Smile programs, but it was not very targeted. But now now what we are doing is it's very, very targeted. We'll have one person train the same mentee for whatever it takes, 2 years, 3 years. So that there is no break in the kind of training that mentee has. There is a variety of ways that we can do. I think collaborations with the universities is the key. This has been spoken a lot today. Is like, just find what the real needs are. They might differ within the countries, within the regions as well. So don't assume, don't prescribe before we actually find out what the real needs are. Collaborate with the local universities, medical institutions, and just maybe also, if there is a chance of policy advocacy, like how can um, institutions in the US help certain countries which do not have a plastic surgery program. There are many countries who still send if there are people, the doctors who want to be a plastic surgeons. In certain countries, especially in LAC, they have to go to Colombia, Brazil, Mexico, Peru to get that plastic surgery degrees. But then if these, the high, the, I'm sorry, the medical institutions or the ministries of the medical institution in these countries can collaborate with universities from Europe and US, just to find out how do we start a plastic surgery program, what are the requirements, what can be the curriculum, how can we can have that bidirectional program where you can send your students here to what Dr. Ampoma was saying is a high volume kind of situation, and then how can we come to you and learn the best practices. So I think that collaboration is certainly the key here, and just finding out the needs, and then just working towards that.
Thank you, Dr. Gurov. Dr. Visava, you did speak a lot about having partnerships and surgeons from the US coming to train surgeons here in Peru in a sustainable fashion. Is there anything else that you'd like to add about optimizing the education of local surgeons through collaboration with surgeons from Europe and the US?
Yes, we have a good experience with the collaboration in long time. No, I think it's a good idea to improve the knowledge. With Operation Smile, we have a long partnership in different hospitals in Peru. One is in Callao. Callao is part of Lima, and the population is more than 2 million people. And in this hospital, we have a mission for many years, and all of the doctors who work in these hospitals have the skills and have a work like a teamwork and prepare the comprehensive care for the cleft and palate. I think this is a good experience here in Peru. I worked in several years in the Children's Hospital. We have a comprehensive care team for cleft and palate, and very similar for the Operation Smile team. And I think if we have the train with a very compact team who provide all the needs that the patient require, I believe the patient receive the perfect treatment. But not only, but this is one of the experience, but But I can talk about the different experience, not only for plastic. No, in my hospital, but it's one of the biggest hospital, I receive other type of mission, like a heart mission. No, in heart mission is the same. Our cardiovascular improve the knowledge and resolve more complex pathologies because a group of the cardiac visit year by year and improve the knowledge and resolve most difficult problem with the children. So I believe that is the way, no? Permanent, many years, same doctor, same trainee, and I believe that that is the way that we can, or they can help us.
Thank you, Dr. Visava. Dr. Ampoma, you spoke about the partnerships that you have with Operation Smile. Is there anything you'd like to add about how can we optimize the education of local surgeons through partnerships and collaboration with surgeons from the US and Europe? I think you're on mute, Dr. Ampoma.
Sorry about that. Yeah, so just for emphasis, I'd like to also talk about the idea of identifying hubs in the low and middle income countries, where you can optimize training. Because sometimes if you want to help and you spread yourself too thin, you do not really make a meaningful impact. So it's important to identify hubs where you have good local leadership that would also pass on the torch, as it were. And that's one. The other thing I also like to touch on is and this is to the American Association of Plastic Surgeons, that we have a large pool of very experienced people who are semi-retired, who are in good health, semi-retired, have a bit of time, do not have too many family commitments, as it were. And this is a good pool of resource to tap into, to use to support LMICs, and so these people can easily, because of their past experience, can easily serve as mentors and, visiting professors, etc., and help to provide some kind of consistency to the various programs that would be undertaken. Because, I mean, in the younger group, they are quite busy, and you also don't want a situation where somebody comes just one trip in many years, because those, when there's that lack of consistency, it doesn't really help. And sometimes too many cooks can spoil it. So it's good to have some kind of consistency, and I think this pool of resource persons is very helpful. As I said, the exchange, the visit exchange, because learning goes both ways. So there's also a few things that we can also, the LMICs can also teach those from the more advanced sectors how to do things simply and in a less expensive way and still achieve good outcomes.
Thank you, Dr. Ampoma. And in line with what you just said, Dr. McKay left a comment on the Q&A section saying that he thinks it is important to recognize that US surgeons also learn a lot from colleagues in their LMICs, and that this is true for attendings and residents, and he feels privileged to be a part of these partnerships. And we completely agree. Learning does go both ways. It's very exciting. I actually trained under Dr. Visava at the Children's Hospital. And as a resident, it was really exciting to, when we would have the surgical missions, 1 week of hand surgery, surgeons coming from the US with their residents, with their nurses, with their anesthetists, their whole team coming to our hospital to teach us. And I'm sure they left with some knowledge as well. I don't know if you have any more questions from the audience.
Bustamante, let's just say I think there's another. Daniel Corlo is putting comment, but while they're doing that, I just wanted to make a few comments. Thank you all for this very comprehensive overview. I know we want to finish in the next 8 minutes, so I don't want to take too much time, but just summarizing some of the things that you've mentioned, and from my perspective, I think you've all brought out the fact that the number of plastic surgeons to population is very low, like 2,000 serving 1.4 billion. is about 1/10 the number even Peru, where 500 is serving 35 million. So we know that's low, but then it's accelerated by the problem because those few that do come out, so many are in cosmetic surgery, and then their distribution is towards the urban, not the suburban areas where people live. So all of those are problems that have to be identified. And the reason I bring those problems out as highlights is because if we are going to go to the final thing, which is advocacy, we're going to have a hard time convincing your governmental bodies if they see those patterns. So the certainly the number is something you can focus on, but they'll say, how are we going to see outcomes to show that we're serving the population? So and this the problems you've identified in your countries is really no different from the problems we have in the United States. As Gaurav, I'm sure, knows, having been here a long time, that we have the same thing. Our people going to cosmetics, they go to urban areas. And for that reason, our ability to get new residency positions is also limited because the government, whenever they open up residency funding, they're doing it for rural areas. So we have to demonstrate that we're able to do that. So just something to think about as you just see how we're going to distribute those trainees. The next thing I wanted to just comment quickly on was the bidirectional learning, and no question that that's so important. And when I go to another country, my ability to contribute, and I think Don Mackay, who's on, will probably agree, is much greater than when people come here because we have such restrictions in the United States that you come in an observership, and our ability to have that real, meaningful bidirectional exchanges is less. When I go to work with someone like Gaurav, it's almost like playing soccer between two people who can react to the ball. I remember just when doing something with Goro, I was showing him how I got to the septum in a primary cleft, and he said, "Oh, I've never done it this way," and I was so surprised because everything I was learning was from him. So it's really a bi-directional learning, and it is like playing soccer. We say, "Okay, this is how I'll react to the ball next time," and that kind of learning we have a hard time replicating in this country. So I just bring that to everyone's attention that sometimes that learning is best in your local environment. The Then going to the concept of education, training, and research, I think that we certainly do want to help with research, but I think where we can be of greatest impact is us importing our skills to your needs because we're not here to study TGF beta in a mouse. We're rather here to study population outcomes with different types of interventions, and that's something that you can guide us to so that we can direct our research teams to best help you. So again, that's a bi-directional effort as well. And then I just want to finish up with policy and advocacy. As I alluded to in the beginning, we have to show tangible points to whoever we're going to try to convince. And Gaurav nicely said how he went to the Ministry of Health and got some things done, but really the most effective advocacy is through your organization. So if Gaurav was then taking the Indian Association of Plastic Surgeons to that group and saying, I have the organization speaking for me, it may be more effective than you just going directly. So for that reason, and we have the same problem here, we have to do it through our national organizations, the ASPS, and then going to the American College of Surgeons. But we can use that as Gaurav said, when we come to those countries, it's an incentive for the government to recognize that something might need to be done. But if we don't have that experience in our own country, we can't direct you. So it's something we all have to get involved in as advocacy. I think it's the most important thing in your own country, and then hopefully use that as a template to stimulate other countries. So there's just some comments I have as we wrap up.
Thank you very much, Dr. Arun. And in light with what you just said, Dr. Corey Liu is talking about the return on investment on policy and advocacy and how the surgical return comes in about 8 to 10 years. And it's difficult because political cycles are 1 to 4 years. So politicians want immediate results, and we all know that policy and advocacy takes a little while to work. So it's a very important thing to keep in mind.
And one thing I want to recognize, Ruben Ayala helped us so much in organizing this. I just want to express my deepest sympathy. Those of you know his father passed away this past week, which is why I don't know if he's on the conference today, but just to pay our respects to this tragedy. So, Dr. Bustamante, I'll let you finish up, and I think we're getting close to the end.
Thank you, Dr. Arun. We do have another comment about Dr. Corlew, saying that he would like to emphasize Dr. Visava's comment about re-education. That education is not a few days or a week. It is important to being part of a training program in an LMIC actually helps that developing surgeons and having constant exchanges. And I completely agree with that. If you go to a surgical program, and Gaurav will tell you, Dr. Ampoma as well, being part of Operation Smile, you won't learn cleft surgery in a week. So you need constant training. Techniques are evolving. There's little tips, little tricks that you can gain from each surgical program. And that's one of the most important parts of that, US surgeons can do for us, coming to us and train us, not just one time, but coming sustainably over years, so that, like Dr. Visava said, we don't just want to train one surgeon or two surgeons. We want to have teams. So we need to train our nurses or anesthesiologists, the whole environment, so that everything can improve and evolve. So and in light of that, I want to thank the American Association of Plastic Surgeons for bringing this very important topic to light. Dr. Arun, our panelists, Dr. Ampoma from Ghana, Dr. Gaurav from the US and India, and of course, Dr. Visava from Peru. Thank you so much for your incredible insight today. Yeah, thank you.
And to let you know, this
Thank you.
webinar is recorded and it will be in our archives. So for those of you or your colleagues who could not do it, if you go on the homepage, there's a link to the association webinars. And so this, along with all of our webinars, will be there. So don't feel pressured if if your colleagues didn't get to see it today.
Thank you.
Thank you.
Thank you all.